Okay. So, firstly, does anybody have any cases that they can think of off the top of their head that they're like, oh, this was amazing. I really want to discuss this one? Not really? I didn't expect anyone to be able to think of one off the top of their head.
Not really. I am working on a couple because I know we had this chat, and I think I just haven't communicated with you before today about whether I do it. If a couple of things that we don't need to talk about today, but just in the future, if one was pericardial effusions, just like reading and like a little how-to guide and like to be aware of if anyone would find that interesting. And the other thing was, I know it's not very technically challenging, but that I've found that I've started using, which I think would be really cool to recommend to vets if they're not aware of it, is just for if we're diagnosing uroliths. If you guys have seen the Minnesota app that they have, it's really cool. Jane and Zane, do you know about this? I'm sorry if I'm just telling you what you already know, but there's this app from the Minnesota, you know, that we send all the uroliths to. It's so cool. You basically, it's just called MN app on the App Store. And I think we should put a link to ref vets if we diagnose uroliths. You upload all the patient signalment and you can upload a lateral radiograph, and then it uses AI to tell you statistically what it's most likely to be. And they're basically trying to really encourage people to stop taking out struvite uroliths because they're still getting like 44% of their uroliths last year in Australia was still struvite, which really could be dissolved. So to try and encourage people to be more medical and stop surgeons, no, I'm kidding, then to try and diagnose. It's a really cool app, and it tells you. I know we could put in the guidelines, like, you know, recheck USG and pH in 2 weeks and keep on antibiotics, but the app has really, really clear recommendations for each stone type you think it is.
That's really cool.
Yeah.
Do you reckon you could write up a blurb in our preset text for urolithiasis?
That's a good idea.
That would be amazing. And then we can literally just copy and paste it in.
That's a good idea. Preset. Yeah. So if you guys see one, it's a cool app and really good recommendations. Like in 2 weeks, do this. In 4 weeks, do this.
And then the only thing really like applied for us is if you've got a patient sedated on the table, recommend snapping a quick lateral radiograph. Because AI, like if that's a free service, that's phenomenal.
Really cool.
Thing that people should get as much information out of as possible.
Yeah. Cool.
Excellent. That's really good. A really good tip. So what I thought we'd sort of take the opportunity to talk about is when I'm reviewing reports, obviously you see clinicians like proactivity versus like reservations. Like you really see the clinicians kind of true colors coming out in their recommendations and stuff. Which I find really nice. Like I like that there's a spectrum of recommendations and things, and also recognize completely that there's so much subjectivity when it comes to interpreting ultrasounds that there's not like a clear cutoff, like right, wrong kind of thing. But Helen and I were talking about when we should be recommending Ursofork, when we shouldn't be recommending Ursofork last week. And I thought it would probably be a good thing to talk about. Like when is gallbladder wall change significant? And when do we need to kind of act on it? Is everyone happy to have that as the topic of conversation for today?
For sure.
Absolutely. Okay. Yep. Yeah.
I feel like this comes up a lot. And remember even that little one that we had recently at Pittwater, it was a little mini schnauzer that was sepsis and was really bad, and he's got gallbladder changes, and you're like, look, I want to ignore that. It's nice to know. Yeah. I know it's your brain, it's your vibe, but
yeah, I think I said that. I've got a vibe. I'm going to ignore it.
Yeah.
So yeah, it's not very scientific. But to try and apply some science to it, I did just a little, like, very brief dive into like literature on where is gallbladder wall change making mucocele more likely, and that's where I think we should probably like make our line. So let's just make a list of like different diseases that we get of the gallbladder. Hit me.
Hyperplasia.
Yeah, good.
Cholangitis.
Good. Let's subcategorize that.
If it's a cat, neutrophilic versus lymphocytic, plasmacytic.
Good. And probably if we sort of say etiologically, like bacterial versus sterile.
Yeah.
Or fungal. There was a fungal cholecystitis in the fellowship exam this year. I was like, bleh. Who wrote this question?
That's horrible.
It was awful. Good. Sorry, did somebody say another disease?
Yes, yeah, said cholecystoliths.
Oh, good. Excellent. Now I wish I'd done more reading on them.
Mucocele.
Good.
Mucinous hyperplasia.
I think Helen said that first. I've got that one.
Neoplasia.
Yeah, good. And one that we don't really think of because it's so rare, I've literally seen it once, is, I shouldn't say that, I've had it confirmed once, but gallbladder wall hematoma, which can obviously disrupt the contractile function of the gallbladder and therefore predispose to other biliary disease, but in itself poses very low risk.
I've never seen it, but do veterinary patients, have you ever seen a gallbladder torsion?
Never.
Like humans can get, or rupture, we should include, like that weird case you had of that dog that just ruptured its gallbladder.
Yeah. So I'm going to call that, trauma and
Trauma.
Yeah. Good.
Wall edema.
Good. That was so nice. I had a case at NEVS and they'd already done the ultrasound. They'd already seen the gallbladder wall edema. They were already treating the anaphylaxis and they got me in for an ultrasound and I was like,
Yep.
it was so nice. Very easy case. Good. I can't think of any others. Anything else?
No.
Okay. Let's pick off some of the easy ones and just like kind of talk about them quickly. So let's start with edema. Leading cause of gallbladder wall edema.
Anaphylaxis.
Why? Or
Pericardial effusion, but I suppose that's probably not that common.
no, so definitely anaphylaxis most common. So it's in like 94% of gallbladder wall edema presentations are caused by anaphylaxis. I don't know when I read that, but it was very recent. So why do we get gallbladder wall edema with anaphylaxis?
Is it based
Yes.
because of the high concentration of mast cells that are in the gallbladder? And so there's that fluid, sorry, that fluid transfer between compartments when the histamine is released as part of the inflammatory process.
Interestingly, if you do histo on the gallbladders, there's not actually any inflammation.
Ah.
So what that histamine release does, and it's the systemic, I'm not sure about the concentration of mast cells in the gallbladder, but you might be exactly right. But the systemic histamine release and reaction causes closing of the portal valves. So you get this really acute portal hypertension, in addition to increased vascular permeability throughout the whole body. So if you increase hydrostatic pressure as well as increasing vascular permeability, all of a sudden you get swelling. So a lot of that is not actually an inflammatory process. It's just like literally the tight junctions between the endothelial cells just come apart in response to that endothelial, to the histamine. So it's mostly hydrostatic pressure combined with vascular permeability. So then if we know that increased hydrostatic pressure causes gallbladder edema, let's talk about pericardial effusion or acute right-sided failure of any cause. So the only other time I've kind of seen that degree is a like massive PTE where we had this all of a sudden pulmonary hypertension and then cor pulmonale right-sided congestive failure. So yeah, if there's no pericardial effusion, have a look at pulmonary pressures if you can. What else might cause it?
Sepsis.
Yeah, good. So systemic inflammation. And what about local inflammation?
infection.
Yeah.
Yeah.
Yeah. So cholecystitis, we can see gallbladder wall edema with. It's usually accompanied by like a really sick dog. So to get that, you know, those like the types of infections that cause really acute swelling, they're really nasty pathogenic bacteria, right? So it's probably going to be E. coli in there. You're probably going to get swelling as well as like really profound inflammatory reaction around the gallbladder. So it's not just going to be the edema on its own. It's going to be the surrounds of the gallbladder that are going to be significant. And what are we going to see biochemically in these patients?
Inflammatory leukogram.
Yeah. Well,
And-
hopefully, yeah.
ALP increased.
Yeah. Ideally, yeah.
Yeah. Unless it's a cat.
Yeah. In which case, all bets are off. The main thing I think is bilirubin. When they're really that permeable, the bilirubin gets into the bloodstream. So in those really, really raunchy cholangiohepatitis or cholecystitises, they've usually got a hyperbilirubinemia. And as you can use that bilirubin real time to assess response to therapy. But those are the ones, if I see those ones and they're septic, like they've met the criteria for sepsis in that they're neutrophilic, they're fully sick, like collapsed dogs, and they've got gallbladder wall edema and a hyperbilirubinemia and ALP elevation, ALT elevations, then I'll probably start with a fluoroquinolone because I'm pretty sure that's a gram-negative in there to cause that degree of acute illness. That's definitely not in the antimicrobial stewardship guidelines. And maybe we could be using
Fluoroquinolone by itself, or are you adding in amoxiclav?
I do clav as well. Yeah, exactly. Yeah. More for that's probably not good science, but I feel like I need to have a first-line antibiotic in before I start a fluoroquinolone.
Yeah.
But I'd be pretty confident that we'd get away with just the fluoroquinolone, actually. Like, I think that's going to do the job in that setting. But then it's just obviously such a spectrum, isn't it? Like, there might be a gram-positive that's causing profound inflammation. Clostridia is pretty inflammatory. Not that pyrogenic, though. They're not usually that septic with it. Although, yeah, there's a spectrum. But yes, I do clav for the clostridial perspective. So the most common organisms that cause cholecystitis.
E. coli.
Yeah.
Yeah. E. coli. I just mentioned him.
Clostridium.
Yeah. And then
Is it like staph or something? Yeah.
which is weird, like because it comes from the bowel. So I don't know why staph gets there.
Yeah.
But it does. And strep organisms as well, but gram-positive cocci. So when you're selecting antibiotics for the gallbladder and it doesn't look really inflamed, they're not septic, but the gallbladder looks pretty raunchy and the blood tests are really so the clinical picture is supportive of a cholecystitis. If I don't see that really active inflammation and sepsis, then I'm just going to do clav because it's more likely to be staph, strep, or Clostridia. And clav's got some coverage at the concentrations it gets to in the gallbladder for E. coli as well. So it's not great for E. coli, but it's really going to get them out of trouble the vast majority of the time. It's only those dogs that I'm like, you're going to die if I don't get the antibiotic, like if I don't address this infection in the next 24 hours. But most of the time I'll start clav and then say if they're still pyrexic 24 hours after the fact, add in a fluoroquinolone.
Sorry, just a quick question with that.
Yeah.
When you're reassessing whether you need to add in, NRO, for example, in that dog, are you looking for it to be normothermic, or does it just have to be downward trending the temperature or the neutrophilia, for example? Like, is it have to be normal or does it have to be trending normal?
Good question. Probably trending normal, but if I feel like they're going to die without it, like they have to be improving holistically, not just on that one parameter. The neutrophil count's tricky because it lags behind clinical improvement. So you'll get clinical improvement and temperature coming down and the neutrophil count's still on the way up because all those chemotaxins and stuff like that are still having all the effect and it's kind of lags behind. And the bone marrow has like finally got around to responding and kicking out some neutrophils. So you can have a left shift when they're now normothermic kind of thing. CRP is a better real-time measure, but in this setting, actually the bilirubin often is the thing that I use to go, okay, we're winning here. So I do bilirubins every 24 hours in these patients. And it can be a really strong marker of improvement. And clinical. Like obviously if they're like now conscious and eating, then that's a plus. Yeah. Eating is really important actually. If you've got bacterial cholecystitis, what does eating a meal do to the gallbladder?
Makes it contract.
Exactly.
Bile flow.
Yeah. So what do you want to do with your like an abscess, like cat bite abscess? What's the theory of clearing the infection?
Flushing it out.
Flush it out. Exactly. Yeah. So that's where Ursofork and frequent meals becomes quite important. Do you know what component of a meal actually triggers gallbladder contraction?
The fat content.
It is the fat, exactly. And what's the most common cause of partial biliary obstruction?
Pancreatitis. Yeah.
It's tricky, bit of a conundrum. So in that situation, I'm more likely to reach for Ursofork because it's going to liquefy the bile, so it's going to be less sludgy. So it's going to be able to pass that partial obstruction better, as opposed to relying on fat causing gallbladder contraction to flush that gallbladder out. So if you've got partial, and the reason I kind of have just conflated the two different pathologies, like partial obstruction and cholecystitis, is that we know when we have stasis of any body fluid, we're more likely to get infection. So if you've got a pancreatitis with partial obstruction, you're more likely to develop a secondary cholecystitis than in a functioning biliary system. Diane, you look like you're pondering that. Have you got a question?
Oh no, I was thinking about I guess moving on to, when is it safe to use Ursofolk and when is it not?
Mm-hmm.
And then I was thinking about that cutoff of bilirubin that you talk about. And
Mm-hmm.
where did that cutoff come from? As in like a figure of 100, I think,
My
is that
head.
right? Yeah, your head, yeah.
My vibe.
Obviously like taking into account the sonographic findings and that, but I guess it's not really a clear, like hard line, is it? That you go, yes, it's
Really
safe,
not.
no, it's not. Yeah.
No, and actually, so that cutoff of 100 is like, it's pretty safe. So they either obstructed like 8 hours before completely and got to 100. But if they've been ill for a few days, it's the bilirubin is going to be much higher than 100 if they're completely obstructed. Whereas I would argue that Ursofolk is indicated with a partial obstruction because it increases the liquidity of the bile and lets it flow past that partial obstruction better. And I have to say, this isn't just me and my vibes. I went to a talk. David Tweed, TWEDT, is the bile guy, works at Cornell University. And I went to a talk on exactly this topic at ACBIM. And he was like, I use it with complete obstructions. I use it all the time. I use it in everything. It's a great drug. Everyone should get some Ursofolk. Here are the 12 benefits and the one minor risk. And even clinically applied, that minor risk, I've never actually seen it cause gallbladder rupture. So we're very much extrapolating from human literature to say that that's a risk in our patients. And if someone that's got that much, like all he does is biliary disease clinically, if someone's got that much experience and is not nervous about using it, then I probably can be a little bit less conservative about my recommendations as well. Given that we just don't really have evidence either way, we've got to go with anecdotal, and he's the one you want the anecdote from.
It makes sense because you think if just more bile flow ruptures your gallbladder, it's probably going to rupture anyway.
Yeah, exactly right. Yeah. And they're probably like those ones that like are going to rupture because you gave them Ursofolk. They ruptured a day earlier and they needed a gallbladder removal anyway to manage their condition, or like at least surgery to unblock their bile duct. Sure. So you just kind of made sure that the surgery was sooner.
I find I never have people that would pay for a gallbladder removal anyway. So
exactly, it's kind of last
they said that it's not surgery, then I'd go for it.
Yeah. And I actually I think I'd much rather, where I think I am quite a conservative clinician, I'm not going to have any guilt if they rupture their gallbladder when I gave them Urso because of those factors. Like, they'd chosen not to go to surgery. They'd had such bad biliary disease, it was probably going to happen anyway, or it was going to be like, has anybody ever seen a dog die of like terrible, like chronic biliary disease? They're in hospital for like 3 weeks and they just waste away to nothing. It's awful. I'd much rather their gallbladder ruptured and it was clear cut.
And is it pretty easy with the gallbladder ruptures? Do you always see free fluid around them? Like, is it quite easy to diagnose, or can it just happen and you just don't see anything ultrasonographically?
That's a good question. So it depends what the bile is. So if you've got liquid bile, you should get effusion. And you should get quite profound acute peritonitis because bile is so irritant. Whereas in the situation of a ruptured mucocele, quite different. They commonly don't have any free fluid in that situation. Do you know why?
Because it's so thick?
Yeah, it's not actually liquid. So little bile salts and crystals like leak out through the wall, but they don't actually cause, and the effusion that you get is inflammatory rather than a bile peritonitis.
Yeah, we had a case, I can't remember, it was maybe Thornley, I can't remember who was with me, but had a gallbladder mucocele and had a bit of effusion next to the gallbladder and it looked pretty bright. So it's, you know, concerned it had ruptured, but then went to surgery and it hadn't ruptured. So the clinician got back to us and said they didn't find a rupture at surgery, which is good for the dog, but the dog was pretty sick. So yeah,
I would argue with that.
I don't know if that's what the other clinician got back to me and said, dog's doing well. They didn't find a rupture at surgery.
Was it a specialist surgeon?
Yeah, went to TPS, I think.
Yeah.
Yeah.
So what happens with mucoceles is actually they don't pop. It's not spectacular. You don't end up with a mucocele floating through the abdomen or anything. But what happens is the wall actually gets focal areas of necrosis. So and it actually cracks. Like, if you read the histopathology report, the wall actually is so brittle that as it tries to contract, it gets little micro cracks in these necrotic areas. So and the bile inside is solid. So it's not that it's ruptured. It's that it's not it has no integrity anymore. And then as the liver is trying to push liquid bile into this rock against resistance, because I think pretty much every dog with a mucocele has a dilated common bile duct. So there's increased resistance in that biliary system because of the degree of thickness of the bile. So the liver's trying to push bile into that structure. That's going to leak out, but just in amounts that are so small that you're not going to get this abdomen full of fluid. So yeah, it's we didn't find a rupture is probably open to interpretation. Doesn't mean there wasn't peritonitis. And what if not a rupture, what is that peritonitis caused by? If you see inflammation around the gallbladder, it's not infected. You know what I mean?
Yeah, that's what I was thinking at the time. And
Did they take it out anyway?
They did take it out. Yeah. They went to emergency cholecystectomy. Yeah.
So it was
Yeah, I
kind
think
of
that's the report.
regardless of what I was thinking.
Sorry?
I was just saying it probably would have improved anyway because they took gallbladder out, so they wouldn't have known if they'd missed the leak that was happening.
Yeah, exactly. They just package it up and go, no leak here.
Zane, what were your ultrasonographic findings that you thought it had ruptured?
I might look this case up. Thornley, you said?
I think so. So there was a little bit of anechoic effusion of free fluid next to the gallbladder, and it's quite bright around the gallbladder.
Sure.
Hopefully the bile duct was dilated as well. I think so. I don't remember all the findings.
Yeah, no, that's right. Yeah.
Liver enzymes were through the roof. I don't remember how long the history of how long the dog was unwell was, but I think it was supposed to come back for a recheck for elevated liver enzymes and it didn't come back. And then when it came back, it was really sick.
Oh, okay. It would be interesting to see what the histo report would say, because Anna said about the necrosis, the last one that I had in Borgola that we took the gallbladder out, hadn't actually, I thought it looked horrendous on ultrasound, and it didn't, at surgery, it didn't actually look like it had ruptured, but the histology report said that, I think it was something ridiculous, like 60% of the gallbladder wall was necrotic. So even though it doesn't look like it's ruptured, like it, yeah, like Anna said, it was a really interesting histology report. So it might be like the same as that one, even though they didn't feel like it had grossly ruptured, it was still dead and disgusting.
Fine, Anna.
Yeah, I did. Yeah, floor cut.
Yeah, floor cut. That's
Yeah.
fine.
Let me see if I can share my screen.
I don't think we had asterisk.
You did.
We did.
You did? Yeah.
Oh, okay.
Ooh,
Well, there you go. Perfect.
Ooh, good.
fun.
Yay.
Okay.
Good party. Okay, so what are we seeing?
Ooh, yeah. So there's a
Ooh.
little bit of anechoic free fluid, like saying
Mhm.
just cranial to the gallbladder there between those liver lobes.
Looks like it's mucinous hyperplasia. Well, I guess it's, well, probably mucocele because it's extending into the center of the lumen.
It's really irregular. Like the wall looks like it's almost like ruptured and folded in on itself.
Yeah.
And what about the gallbladder surrounds? If we're sort of saying inflammation is the kind of indication for surgery.
Yeah, you can see in this view, oh, hang on, there, you can see how hyperechoic that the surrounds are. And
Yeah.
actually, I guess if we traced it really slowly, we might even be able to see, it doesn't look like there's a gap in the wall, but we could even have a little look at the like wall integrity and see if there's anywhere that looks like it's suddenly thicker to really thin or something that could indicate
Yeah, a rupture.
a rupture.
Let me see what other videos we've got. I just turned down the frame rate just to make it a little bit. Does everyone know how to do that when they're reviewing videos?
No.
So here is the frames per second.
Mm-hmm.
You can make it really slow motion,
Mm-hmm.
or you can speed it right up if you just want to churn through.
Oh, you can see it's really hyperechoic as it comes down around the cystic duct.
And then you can flick through frames. Like if you see something, you're like, ooh, what's that? What's that? Yeah. So see that?
Yeah.
That's weird. Like that's got to be an area of necrosis, right? Like you can see the line around the gallbladder. So like the serosal surface is intact, but then this mucosal surface here, so thickened and anechoic, right?
Yeah.
And then you've got this little wedge shape.
Mm.
That's got to be a region of necrosis.
That's so interesting because that almost, before that view, that looks like that looks like anechoic bile in the lumen rather than the mucosal surface, and then you can see the difference there.
Agree.
Yeah, and you can see where the lumen starts. Yeah.
So whilst it would be like, I really want to focus on where we go, okay, where is this gallbladder wall thickening significant? Where is it posing a risk to this dog's well-being? And where should we be recommending a support or cholecystectomy?
Yeah.
So what is the cutoff between like gallbladder wall thickening, mucinous hyperplasia, and mucocele, basically? So this is a slam dunk surgical case to me. Like there's peritonitis surrounding the gallbladder. That gallbladder needs to come out. If that looked like gallbladder wall edema with peritonitis surrounding the gallbladder and the dog was septic on assessment clinically, then I'd say, okay, well, maybe we might be able to manage this medically if it's a like cholecystitis, for example. But does everyone agree that that wall is not a cholecystitis wall?
Mm-hmm.
Does everyone know why I'm saying that? What
Usually,
cholecystitis
cholecystitis walls are sort of thickened and hyperechoic, and it's really easy to see that they're sort of, you can follow them all the way around, I guess.
And maybe more uniform the whole way around.
Yes. Yeah. So the mucosal, like luminal interface is like, it might be really irregular, but you can really see where the bile starts and the wall starts. Whereas here I'm like, oh, that's like, there's wall inside that gallbladder. Why is that? You know, it's really sort of messy. And then whilst we do see gallbladder wall edema with cholecystitis, that's uniform. Like that's a ring around the circular gallbladder, as opposed to this, which is like that anechoic wall, but very irregular. There's no way that edema can cause that folding and waviness of the wall. So what is it, if it's not fluid in the wall causing that anechoicness, what is it?
Cells, inflammatory cells. Oh, anechoic, sorry.
Yeah.
Is it the mucin? Like, is it?
Yeah.
Yeah.
Yeah. It's mucus, basically. I'm going to stop sharing that because I do have a couple of extra things, pictures and videos. If I can make it work. Good. So that's sort of the keys to differentiating cholecystitis from mucinous hyperplasia is the regularity and undulation of the wall. Does that make sense to everyone?
Yeah.
Okay, so what about, I don't really know how to do this. Nobody give me a hard time about how many windows I've got open, okay? Come on now. Okay, what about this wall? What do we think of this? Did you see it?
So we can see like the serosal surface, which is really bright, and then we can see the wall. So that's this little bit that's like the most gravity dependent area. That whole thickening is that all wall itself rather than material that's stuck to the wall, and it's got a more hypoechoic area inside the wall and then a more hyperechoic area.
I think that's most likely. I couldn't say for sure. It's not adherent bile, but you can see there's definitely undulation of the wall, right?
Yeah.
And then this wall is starting to get a little bit black, isn't it?
Yeah.
Or a little bit darker than we'd expect with like a cholecystitis.
Yeah.
But this could easily be somewhere between cholecystitis and mucinous hyperplasia. The key then is going to be like, okay, well, what are our liver enzyme changes? Is there evidence of active inflammation clinically or ultrasonographically? Or is this kind of an incidental finding due to just an elevated ALP, for example? So in these cases, I've almost like feel like I want to take a poll because I reckon all of us would probably recommend something different when you see this. Like, this is probably one I'd say, if they're keen owners, I'd probably put it on some Ursofork. Would anybody disagree with that? Nobody disagrees with me.
Would you say, irrespective of what, so for example, say the patient was in for something unrelated to hepatic or biliary disease while we were scanning it, and its ALP was 350 and the rest of its biochemistry was normal?
I'd probably recommend a repeat ultrasound in 3 months.
Okay. And what about that same patient, but its ALP is 1,000?
If you said 1,500.
Okay.
Wow. Did you hear that?
Was that thunder?
Yeah.
Oh,
but like the lightning was like right on top of it. You all right? All right. Yeah, so probably 1,500. I'd probably say, okay, that's getting pretty high.
Yeah.
And what is the most common cause of mucinous hyperplasia?
Cushing's disease.
Cushing's disease, yeah, it's actually endocrinopathies. So I'd probably say this patient, like clinically, they're really well. We're just investigating like acute vomiting. They've got an incidental finding of an ALP of 1,500. but no other evidence of illness or inflammation, I'd probably say let's start screening for an endocrinopathy in this patient, or at least like quizzing the owners on their, like, whether there's any signs of Cushing's, hypothyroidism and stuff.
Okay.
Where typically I like to wait for signs to develop before I start screening for an endocrinopathy. I might be a little bit more proactive in a case that had these changes that I thought this is pre-mucocele. I found a really interesting paper where it made associations between the thickness of the wall and the likelihood of progressing to mucocele or not. So if you've got these changes and the wall thickness is between 2 and 3, and the lumen is not papillary, do you know what I mean by papillary?
Like all coming out into the lumen.
Yes, exactly. But sometimes we see that with chronic cholangiohepatitis. So what that's saying, it's saying we're not talking about chronic inflammatory disease. We're talking about mucinous hyperplasia, which is a different thing. So if you've got papillary change, it's more a chronic inflammatory change. Whereas if you've got undulating wall thickness like this, that is between 2 and 3 millimeters in thickness, oh, it's a big storm. It doesn't actually predispose to mucocele development. So then there's grey zone up to 5. So if you've got gallbladder wall thickness above 5, like this, with that mucinous hyperplasia look with the blackness, and again, no papillary change on the mucosal surface, and no evidence of active inflammation in the gallbladder surrounds, that's a risk factor for mucocele formation. So if you've got wall over 5, I'm going to say let's do Ursofork in those cases, kind of regardless of clinical presentation, because they can be well up until their mucocele ruptures.
Mm.
So if we're kind of standardizing our recommendations, 5 is going to be our cutoff when we've got mucinous hyperplasia. But if it's less than 3, we're not going to do Ursofork because there's no association with development to a mucocele unless they're unwell with biliary disease, in which case Ursofork is indicated for other reasons. My dog is vibrating under the desk.
Oh,
I'm so sad.
that's very sad.
It's so sad. She needs some trazodone, CT. Okay, let me see what else I've got here. I think this is just a still of a gallbladder. Can you guys see this one?
Yeah.
Yeah. So what do you think about this wall?
It's really thickened over 5 and irregular. And it's starting to kind of get it's almost starting to kind of get the like little echogenic striations through the bile in areas. Good. You can kind of see around, so sort of making it lean more towards a mucocele formation potentially.
Good. So more than 5. Doesn't look like there's active inflammation, but obviously we haven't screened the whole area, but the fat that we can see looks pretty quiet. We can't see any pockets of free fluid. So this is going to be one of those dogs that we say high risk of development of mucocele. Look for the underlying cause of mucocele formation, hyperlipidemia, Cushing's, hypothyroidism, and treat with Ursofork for this one.
Do you ever worry about sort of more chronic bacterial inflammation if they're starting to get calcified? Like, is there, I mean, I guess it obviously depends on the cat and the inflammatory leukogram and blah, 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 but I guess if you've got calcification areas, do you worry more about bacteria smouldering away in there?
Yes. Yeah. So mineralization is definitely associated with bacterial infection chronically, but we actually think that the etiology of all feline cholangitis is bacterial. It's just the pathogenicity and how unwell they make the cat that depends on their presentation. So that neutrophilic cholangitis is just a very pathogenic organism that makes the cats really sick, causes an inflammatory leukogram, and we get signs of acute inflammation in the gallbladder. whereas a bacterial infection, that's long-standing. And I shouldn't say infection, because there's this like enterohepatic circulation thing where the like bacteria go up the portal system and then come out through the biliary system, and that's part of normal kind of immune tolerance development. But there's bacteria when you do like fish, the fluorescent in situ hybridization studies on feline gallbladders, there's always bacteria in there, pretty much. And it's just whether that bacteria is, maybe there's some stasis or underlying disease, or they are chronic vomiters and they get a lot of ascending bacteria as well as that enterohepatic circulation that leads to that inflammatory response. So it's not. Sorry.
Oh, sorry, I didn't mean to cut you off. Sorry.
No, you go ahead.
When you say all feline cholangitis is probably bacterial originally etiology, when we're treating, like if we're treating a lymphocytic plasmacytic with steroids, is that really just because they're then getting a maladaptive inflammatory response to it rather than, okay.
Yeah. So what's making them sick is actually the inflammatory response, and we expect a degree of bacterial. Oh, this is interesting.
Rather than it being like a primary immune-mediated disease.
Yeah, exactly. And it is like, what is immune-mediated disease?
Yeah, I guess your maladaptive immune system.
Yeah, exactly. Yeah. So it can be actually autoimmune, where there's antibodies directed towards cell, or it can be a maladaptive response to normal antigenic exposure, or excessive antigenic exposure, which you can't really address. Can't have the cats on antibiotics for their life, but you can manage safely, because it's a system that flushes itself. You can safely manage them with Ursofork and like medical management.
Yeah,
decrease that inflammation. Yeah. And typically these cats, and they're not cats that we're putting on immunosuppressive doses of pred.
Yeah.
Putting them on anti-inflammatory doses of pred. So whilst we're suppressing their immune response slightly, it's not a terrible crime.
Yeah.
Small crime.
Yeah, that makes sense.
Okay, what do we think of this gallbladder?
Ooh.
Ooh. Quite focal, isn't it? Oopsies. Do you want to see it again?
Yes, please.
Oopsies.
So it looks like there's a lot of echogenic, sort of well demarcated solid bile in the middle, and then surrounded by some more hypoechoic. Or that could be the whole wall, actually.
Yeah, I'd say it looks like it's got mucinous hyperplasia, but then the wall itself is hyperechoic beyond that. And there's some little focus of calcification sitting outside the gallbladder.
That too, yeah.
Yeah.
So if we scroll through slowly and we see just up in here, see these little bright spots with little shadows? See that?
Yeah.
So that's a marker of inflammation that's more widespread than the biliary system itself. If you look at where those bright spots are, they're right next to the portal structures. So, but I'm pointing at the screen. You can't see my pointer, but sorry. So you'll have to just believe me. So often we get these little pinpoint mineralizations next to portal structures, and then over time with chronicity, we actually get like stripes of mineralization adjacent to portal structures. And what runs adjacent to portal structures?
Your little bile sinusoids.
Yes, good. Yeah, in that little triad. Remember the little triad? Hepatic artery, portal vein, and bile canaliculi and sinusoids. So they run adjacent. So where we see those stripes of mineralization adjacent to portal structures, and then gallbladder changes like this, we can say that there's quite widespread cholangiohepatitis rather than just cholangitis, or cholecystitis, I should say. So I was challenged actually, because my definition of a mucocele is when there's no liquid bile in the gallbladder. That's kind of what I was taught. And I can't remember where I read that or where I learned that. But in the process of this deep dive, I've had that belief challenged. So I've probably led you all astray over the years of training you. At what point do you guys think we should call something a mucocele?
Weirdly had it in my head that it had to it had to reach the center, the projections from the wall. I don't know where I got that
What
from.
about when it's unilateral like this? Like, so I actually think we've got here on the like, it's running away. So here, can you see my pointer?
Yeah.
Yeah, good. This is all wall. This is a little bit of wall with mucinous hyperplasia up here, that black part. This is actually liquid bile. So this patient doesn't actually meet my criteria, my old criteria for mucocele formation. But what this paper said is actually when the wall exceeds 10 millimeters at any point, it's at risk of becoming necrotic and rupturing. So that's where you say this is a mucocele. So there can still be liquid bile. It can be asymmetrical. But when the wall exceeds 10 millimeters, 1 centimeter in thickness at any point, particularly when you've got those striations, it's termed a mucocele.
Do you ever type them? Like, I don't know if we ever really include that in reports, but I remember learning like you can type them from 1 to 5.
Oh gosh, that's a very advanced, Helen. You can present that next time.
Okay, I'll look into it.
I've got a paper that talks about it in cats and how to grade them, and the paper also refers to the paper in dogs. Wow, sorry, not mucoceles. It was more
inflammatory.
What was it? When we were looking into the cholangitis, so it was talking about the degree of wall change, I think, and grading those in dogs and cats. So maybe it was referring to, yeah. But I've got the paper anyway that graded the dogs.
Okay.
Yeah, I can talk about it next time. It was a 2013 paper as well, but yeah, like type 1.
My time after I studied.
Type 1, immobile. Type 2, type 3, type 4, type 5, right up to type 5, like kiwi-like pattern.
Yeah, right.
Blah.
And does that then draw clinical guidelines or recommendations?
I mean, that would really be the only useful reason to
grade them.
To bother putting it in our reports. But I'll look into it for next time and see if the grades have any bearing on on clinical recommendations.
Cool.
Oh yeah, there's a couple of papers. Yeah, I'll look into it.
All right, Helen's job to do a deep dive. So that's kind of all I wanted to go through, like just a couple of pictures and like how our clinical recommendations can like be a little bit standardized based on wall thicknesses. There's no right or wrong here, and we really need to base our recommendations on the patient's presentation more than our ultrasound measurements. So please don't feel like this is what you must do because we had this talk. If you get Ursodeoxycholic vibes, go for Ursodeoxycholic.
Anna, just you said about the 10 millimeter thing, we're measuring any wall over 10 millimeters. Do you think it's then reasonable for us to put in the report about discussing a preemptive gallbladder removal because it's like more likely to be necrosed, even if it's not why they're there?
Yes, I think so, particularly if their presentation is chronic vomiting, because that's the most common presentation with mucocele. So it might actually be the mucocele causing the vomiting, even if there's not any ultrasonographic evidence of inflammation.
Yeah.
If they've got normal liver enzymes, I'd really struggle to recommend a gallbladder removal.
Okay.
But the chances of that are very slim.
Yeah.
The only other thing I'd like to highlight is that sometimes you can see that mucinous hyperplasia, and if you don't have sludgy bile to contrast it, you can't see it. Like if the bile is anechoic, you can't see the anechoic wall thickness. So always make sure you're checking gravity dependent location. And I guess being like, if you've got a patient with really raunchy liver enzymes and a really like just all anechoic, maybe switch to the linear probe or make sure that you're maximizing your frequency or resolution so that if there's some subtle striations in there, you've got every chance of seeing them. I have actually called a gallbladder normal and then changed the probes and gone, whoa, that's a mucocele, actually. So yeah, definitely worth just making sure if you're suspicious, make sure that you're checking your image quality. Any specific topics that you guys want to cover? So Helen's mentioned pericardial effusion. Just Helen, we did do a tutorial on pericardial effusion probably a couple of weeks before you came on board.
Oh, that might be a bit boring then.
Well, I'm wondering if we recorded it.
Yeah, I went looking and I mean, it's probably me, I couldn't find it, but there was a few recommendations in there that I wanted to check and I couldn't find it anywhere. So I wondered I think you said you were going to send a paper out that you were referring to.
This is why I need trishing meetings. Okay, let me see if I can find that, but otherwise
what
we
was
can
the measurement that it was safe to drain? Was it like a centimetre?
I use a centimetre. Yeah. There's no consensus on that, but I'm just like, if you put a huge needle through a pericardium, like, and have that little buffer from the bevel before your catheter's even in, like you can't do a 5 millimetre one with the size catheters that we're doing. It's just too tight.
And hopefully you don't need to.
Well, and that's the other thing. If it's very acute, it can be quite low volume.
That's true.
Because the pericardium actually constricts it, so they can have tamponade without a huge volume. If it develops over time, they can be massive.
The only other thing that I wanted to chat about, and doesn't have to happen today, is just to get my head around the typical metabolic looking liver that we see on 50% of our cases. So the ones that we're kind of saying the differentials being endocrinopathies, like Cushing's, hypothyroidism, hyperlipidemia, is some of those going to have either vacuolar hepatopathies or nodular regenerations that actually don't have all of those things? Like I just worry that sometimes if I put that in there and I have a vet that then does Cushing's tests and thyroid tests and triglycerides and they're all normal and I've made them spend a lot of money and not warned them that it could be other things apart from those three.
So I'm feeling the same level of discomfort, and I'm more and more saying it could just be a high fat diet and increased like lipid metabolism through that liver. Like if there's no clinical signs, don't test. So I would like maybe change diet before I did testing in a clinically well dog. But what I might do, I might see if there's any paper, because this must be a question that's asked often. I might see if there's any papers or guidelines on what you do at what point, like if the ALP is this, then this, regardless of clinical signs. I don't think there is, but it would be good to look into. And it is tricky because we don't have all of the clinical context either. Okay, so I'll see if I can find the pericardial effusion one. And if you've got specific questions, Helen, we can like do a truncated version in the next meeting. So just put any specific questions. We'll put in the like action items of the like meeting in ClickUp. Do you know where that is? So like where we do the agenda for the ops meetings. Specific questions in there, and I'll try and address them first. And if there's specific cases, just add them in as we go, because like questions come up as you're working, and it's very hard to remember them in this environment if we're not putting them in the list as we go.
Yeah, sure.
Good. All right. Get to work, everyone.
Thanks, Anna. That was awesome.
Thanks, Anna.
Thank you.
See you soon. Bye.
Right. Bye.
Thanks, Anna.
Cheers, Nerily.
Anna, are you away next week?
Yeah.
Okay, nice.
Yeah.
That's exciting.
It is exciting. I'll see you tomorrow though.
Yes, amazing. Yeah.
Yeah.
I want you to come and scope that PLE dog, but maybe we'll do it not next week, the week after.
Good. Yeah.
If he's still alive.
Is he not going well?
His ALT is now 5,000.
Fuck.
Yeah. And I don't really know.
I don't really.
No, he's fine.
No, he's not.
He's fine. He's honestly fine. Well, he's not fine. His albumin went from 10 to 11 to 12 to 13. It's now 14.
Mm-hmm.
Terrible. His globulins are 21. Terrible. And his ALP's now was like 100, then 700, and now 5,000, and he's still losing weight.
ALP or ALT?
ALP. His ALP is normal.
He's got a hepatitis.
But why?
I would say neosporosis.
Ooh.
Dog's on pred. I think it's probably unrelated.
Ooh.
Yeah, I'd be nervous about that one.
I'm very nervous about him.
Yeah.
Yeah, we've changed his plan a tiny bit, but I'll do it while you're away. I mean, I don't really know what else I can do for him in the meantime.
I would do a neosporosis PCR.
Okay.
That'll give you more accurate, like a faster result.
Yeah.
But yeah, they develop pneumonitis and stuff like that. They can go downhill really quickly. Adults with like reasonable immune systems should be all right, but given we've only recently upped the pred, I think we might have like compromised that.
Okay.
But that's a very that's not a pred ALT. Like there's no reason.
No, it's he has to have something else.
Yeah.
He's like well in himself. Yeah, the owners are like, yeah, he's kind of fine. We just
the hepatitis on pred, like there's no autoimmune causes of that, like it's infectious. So
because the only other time I saw that was a cat that had toxo.
Yeah,
it was on
cortisol pattern
on pred for lympho. Yeah. Do I need to test him for toxo as well?
Do the PCR panel.
Okay. Yeah. And should I put him on clindamycin?
PMS better.
Say that again. Sorry.
PMS is better.
Oh, right. Okay.
Neospora.
Yeah. Okay.
And then
great.
if it comes back positive, we'll add in pyrimethamine, which is the specific like antiprotozoal.
Sure. Yeah. Yeah. Bill Bailey just emailed me his results this morning. I did bloods yesterday, and I was like, oh, okay. I need to call his mum. I'm going to chat to her again. Well, I'm going to offer her a full referral again today. I don't know. She just seems not keen on that. But and otherwise, if he's going okay, I might stop his rivaroxaban, and then you could come see him when you're back. Yeah. Do I need to stop his pred? Or well, I'm going to stop it anyway because of this. Like, should I halve his pred?
You can't just stop it. He's going to tank and burn with his gut stuff.
Should I drop it back down to 1 mg/kg?
Yeah, probably.
And then does he need to stop that before biopsies?
No.
No.
We
Okay.
can't. He'll die. I've got to go, Helen. Sorry.
Sorry. This is not.